And I invite my very old good friend, a scientist, Dr. R.C. Shah. He is a very prolific surgeon. He has a practice in Bombay. In fact, he's one of those who has the courage to call his clinic 6 by 4 clinic. So that means he delivers that. And there are a lot of innovative ideas that come into his mind, and he and his friend, they always come out with such additions into, ophthalmic instruments and drugs. Over to you, Dr. R.C.
Thank you, Dr. Haldipurkar, for giving me the opportunity to speak on this dais. Evolving lens technology and my approach. Evolving lens technology today is trying to rectify the previous mistakes which we have done because of the lens design deficits. Now, what are the deficits which you have seen? I have done about 19,000 multifocal lenses so far. I started in 1989 with IOLab bifocal lenses, diffractive all multifocal lenses, gone and visited most of the factories except one, and I have learned a lot of things, how they manufacture, how the designing is done. So today I am sharing my experience of 19,000 and almost 30 years of experience. Now, what were the deficits which were there in the past? First, I will discuss in monofocal the edges of the anterior and the posterior surface. The glistening material which we all aware of it, in spite of that we are all using it because of the financial gains. Aspheric and spherical aberration IOL first was introduced by Technics platform of 0.27. I visited and met and stayed with him for a day. Tom is the scientist who did this thing, and he explained the things, and from there my journey to understand the IOL technology started about in 1995. And the 6 mm optics which were there in the, these are the errors of the past. Now we have most of the lenses which are of anterior square edge. The most important which we got is the posterior surface, which is a double square edge, which is known as an enamel double square edge. It was introduced probably by Rayner for the first time. Here you see in this picture, you can see that two edges are there next to each other. So it has got a double barrier of posterior capsule opacification. Coming to the material of the IOL, which has taken a progress in the science. First is hydrophobic, hydrophilic, all of us know about it. The next one which is expected to come in next 5 years is the fluid optics. The fluid material which will be delivering us the accommodative IOL. Surface modified which was there in the past, heparin coated, which has worked very well with uveitic patients. And now most of the manufacturers are shifted to hybrid material. So it behaves like an hydrophilic when you deliver the lens in the eye, but it behaves like an hydrophobic as far as the PCO is concerned. These are the few accommodative fluid IOLs which are expected to hit the market in next 5 years. They are all in the investigation in the United States. It has got a double optics, you can see here, and these optics moves in front and back whenever there is an accommodation which will change the blue portion of the lens. Second one is here, which is known as the Omni view, which will be again in the process of investigations. If I am not wrong, this particular lens has got an US FDA approval recently, in which whenever there is an accommodation, this fluid comes in the center and changes the power of the lens. And the last one which is there is jealousy, where the lens moves with the accommodation, the contraction and relaxation of the ciliary body with the change in shape of the capsular bag. Then came the large optics. We were the first one with Dr. Kakadia in our company. I have a financial interest in that, where we created a 7.5 mm large lens to negate the negative dysphotopsia. The lens name is Autofocus Pro, which is a varifocal IOL. Rayner is the other company which has got a collar strut technology, where you keep those two collars on the temporal part. This will also help you to avoid the negative dysphotopsia. This is already Tanvi has told you about the various spherical aberration lenses. Now we come to what are the deficit which was there in the multifocal lenses. All of us now moving away from the ring refractive IOL. It might be something which is little strange, but in next 5 years, the ring IOLs will disappear. It will go to number of varifocal lenses which are expected to hit the market. Recently, one IOL company got approval from USA, which we expect to hit by December in our country. Moving towards uniform distribution of power of light from center to the periphery. Here we always have some part is distributed, elongated focus. They are all very good, but over a period of time, this will ultimately disappear. And our is the only lens which has got a uniform power distributions in all 360° from center to the periphery. Moving towards truly pupil independent. This is something which is going to be little difficult even for us. Moving away from micro and mono vision, because most of the patients wants to see clear for all the things. Moving towards photopsia free IOLs. Probably this might be a distant dream at present. Then we need to have a continuous vision. I have given you the one paper which will help you to find out your own way any multifocal lenses to find out the depth of focus, and that is a true way of finding out the performance of the IOL. And this is what we want. This is what we want. It might be little difficult today with the present technology, but this is what we see in varifocal IOLs, whether it is Autofocus Pro. There is another lens which is available is Lentis. It is coming from Germany, and there is one more lens which is expected to come from USA. I don't know the name, but we have spoken to them, and probably this type of depth of focus you need to do. The whole idea is then you can see in plus up to 1.5 also the patient vision does not change. That shows that even if there is a refractive error of 0.75, without putting a glasses, the patient still sees 6/6. And the other side, which is on the minus side, you will see almost the same uniform. Even if it is a -3 corrections, the patient can see. That means they have a very good depth of focus for distance, and we assume that the same thing is also there for near. So with all this understanding with my friend Dr. Kakadia, we have designed the lens which is known as autofocus spray, and that is what my present approach for multifocal lenses. Can you start the video? It is with the voice.
Hello dear friends and colleagues.
Can you start the voice?
Happy to introduce to you Autofocus Pro, a unique and novel ringless polyfocal progressive IOL.
Can you start the voice?
Hello dear friends and colleagues. Today we are very happy to introduce to you Autofocus Pro, a unique and novel ringless polyfocal progressive IOL which gives excellent vision at all distances, far, near and intermediate, without haze, halos and starburst, which is completely free from negative dysphotopsia. Autofocus Pro looks almost like a monofocal but works like a multifocal. It is an aspheric polyfocal progressive lens without any diffractive rings. It is static and fixed in the bag. There is no mechanical pseudo accommodation, but yet it functions like an autofocus lens and hence the name. Progressiveness of this IOL is visible on 9-day OPD scan, which is much similar to varifocal lenses. This OPD scan nicely illustrates the wonderful progressiveness of this IOL with distance dominance in central area of photopic pupil. This is the sketch of design and dimensions. This is the schematic optic of autofocus progressive polyfocal optic, which gives excellent DIN vision, that is distance intermediate and near, by green technology, that is gradient refractive index. As you can notice, there is no loss of light energy because there are no diffractive rings, so there are no photons which are lost. This is the schematic optic, and as you can notice that even with different sizes of pupil, the ratio of the distribution of light remains the same. These two dialing holes are also position indicators to be kept in upper half of eye. They also help to drain out any remaining retro-IOL viscoelastic. Undulated haptics are inspired from postal stamps border. Haptics are completely atraumatic, just like knuckles of our fist. Resistive but atraumatic haptics can be mentally compared to the surface of custard apples. Large and horizontally oval optic covers full visual field, hence there is no negative dysphotopsia. And 6 mm long L-shaped zigzag-edged haptics provide rock-solid rotational stability. Lifeline Millioptics Autofocus Pro is available as both options, as hydrophilic and as preloaded hydrophobic. This silky, smooth and soft IOL's injection is very easy, as good as any other soft foldable IOL. And as you can notice, unfolding is gentle and slow. And once both haptics are in the bag, we have to rotate the IOL so as to keep both dialing holes in upper half of eye, keeping the IOL horizontal as best as possible. At any size of pupil, light distribution proportion remains the same, hence it is pupil independent. There is no light energy loss because there is no destructive interference or diffraction, and angle kappa or angle alpha are of no significance nor of importance. In this retroillumination, we can barely perceive the different zones of Autofocus Pro IOL. This is the only ringless progressive IOL having all zones in central 0.9 mm area, and hence it is independent of any pupil size. This is the typical post-op fogging over refraction chart, and as we can see that from +2 to -4, the vision remains almost the same, which is almost like 6 diopters of amplitude of pseudo accommodation. This is the typical DOF chart of autofocus.
Because of the shortage of time, Autofocus Pro and the lenses are the two lenses which will give the best depth of focus today, and they are practically free from the dysphotopsia. So the conclusion is moving towards the IOL with minimum or negative, no dysphotopsia, moving towards the continuous vision IOL. Very good depth of focus is necessary for satisfied patients of all the professions. Spectacle independence for almost all distance, and the minimum PCO, and no or near no contrast loss.